Good afternoon. I can see a few folks are on. This is OPCA. I'm Danielle, but we'll get started in just a little bit. I'll let folks join, get logged on, and we'll get started. But thanks for being here.
Hey, Danielle.
Hello, welcome. I'm just letting folks get logged on, get into the audio, and we'll probably start in the next 3 to 5 minutes.
And I'm just as a note, I'm only available till 3:30 today. Got a conflict.
Not a worry. Glad to have you, and yeah, listen in as you can, and then we can get to the slides of recording
Sounds
afterwards as well.
Perfect.
Which to that end, I will get my slides queued up here and going. And Tori, will you confirm for me that you're seeing the presentation mode, not all the notes and all of that?
Currently seeing the notes.
Notes, okay, it does this every time. Thank you. Let me, all right, that better?
Yes, presentation mode.
Perfect, thank you. And as folks are joining, welcome. We're just getting started, and obviously logistics settled here as we get ready to go. We'll start in the next few minutes. As folks are getting settled, I'm going to actually switch or go forward a little bit in the slides here. But if you have a moment and want to use the chat function, go ahead and introduce yourself, if you would, just your name, health center, the role that you play at the health center. And then just for fun, either what your favorite care step is, if you have one that you like to do or that you're used to billing, or a favorite memory or experience in the program. And for folks just joining again, welcome. Thank you so much for joining us. I am just kicking off or getting us started as folks are joining with the introductions. So if you will type into the chat, and it's probably taking folks a minute. Again, who you are, what health center you're with, what your role is, and then what your favorite memory in the program is, or what your favorite care step is, if you have one. And thank you, Christy, seeing your answer of developing that first APCM rate. So you're one of our early clinics, or actually we're earlier in the program, but also getting that rate developed. Casey, appreciate that, how it helps for the wraparound services and reimburse for that. All right, I'm going to give you a few more, about a minute or so more, I guess, to type those answers in, but would really love to know who's here today. And come on, I know you have a favorite memory, or go look up those care steps. There's 18 of them. You can pick one. And thank you, Blaine, seeing the saying that initial face-to-face visit with the problem with the med reconciliation, getting that patient established with your health center. Carla, thank you. I like all care steps. I appreciate that. I'm with you. All right, I don't think I'm seeing too many new folks join. And in the interest of time, I do want to make sure to stay on time. I know it's towards the end of our day, and I promise I'm going to try to keep you all awake in our 3 o'clock post-lunch nap time hour. So with that, I will get us started. But for those, again, joining, or if you're figuring out chat, or if there's anyone who wants to come off chat and share a story, I will stop real quick for that. And then I will get us kicked off. Okay. All right, Glenn, you don't have to be on video, but if you also want to be on video, that's helpful. I appreciate my co-team here and all of my coworkers that are on video that you're seeing on screen. There's a handful of us also supporting today. And then good to see all of you, or at least be able to have this conversation with. All right. Let me get my slides to work here. There we go. So what I wanted to start with, and to give us a kind of grounding and setting the stage for where we're going in the next iteration of the program, or what we're proposing as the next iteration, was to really reflect on the fact that we have had APCM in Oregon for almost 10 years. The actual implementation, right, those first clinics kicked off in 2013, but the work to get an APCM program in Oregon began back in 2011. So we are actually 11 years into the work of APCM, or the APM that we have in Oregon. And again, 8 years into the program itself. And I particularly like this slide. And if you haven't seen this before, or maybe you have in your onboarding or somewhere in your onboarding processes, went through and looked at how many phases we have done from that initial pilot. So when I said 2013, phase 1, or what we called that pilot phase, was back in 2013 with those first 3 clinics. From that time, over the next 8 years through 2020, we grew to 22 clinics. And that is 20 FQHCs and 2 rural health centers within the program. And just as a reminder, again, our program is open to all that get PPS, right? So that is our Indian Health Tribal Services, that's our rural health clinics, and that's our FQHCs. So we have 20 of our members in the program, and then 2 of the rural health centers. And again, we onboarded anywhere between 3 and actually 1 year, 4 clinics into the program. And you should be finding yourself, I hope you're looking at this and also figuring out where you are as a clinic, you know, what phase you were in if you weren't actually at the clinic when your clinic onboarded. Behind the scenes, in terms of supporting the program and really wanting to emphasize the relationship we have as the association, as the state, and as our health centers in making this program successful. I've highlighted here on the left-hand side the staff that do the work at our health center, or at the association. And this is actually really a handful of the staff that are behind the scenes doing the everyday work of onboarding, of our care model transformation, of the policy work that needs to happen to keep the APCM program going. There are more staff than just this, but again, these are the primary staff involved. And then we have our members and consultants. So that is you, right? All of you make this program work, and it's really important to your clinics and to have this program for the health centers. But we also have members then that are engaged as our steering committee, which was the former APCM leadership committee. And many of you may remember when you onboarded, when you started this program, especially my CEOs and probably CFOs, that there was an APCM leadership committee that ran for the probably first 6-7 years of the program. And then we converted to what is now the APCM steering committee, which is just a slightly smaller iteration of that group. It's a more nimble group, and it is something that we put in place back in 2020 as we were getting ready for the next phases and the next part of the program. That committee over the last 2 years has grown from 5 steering committee members to 7. So there's now 7 total health centers represented and helping inform and make those decisions. That committee then feeds up to the value-based pay committee, or is part of and reporting to the value-based pay committee, which reports to the board, so that our board has oversight then of all of our payment and kind of care model programs. We also consult. As many of you know, you've worked with a couple of these names might sound familiar. The first of that being Cedar Bridge Consulting. Jamal Sukwan, who many of you would have known from the States, you had probably worked with him over the years, has actually had transitioned to Cedar Bridge Consulting. Don Ross is also part of that group now. And we use to actually inform this 2.0 work. So what we're going to talk about a little bit later as we get into that deep dive is the work we did with both Jamal and now Don over at Cedar Bridge. The other two names there should look very familiar. Kurt Degenfelter, again, does all of our onboarding rate setting with us when we go through the onboarding process. So all of you CFOs and probably C-suite folks very much know that process and remember going through that process or may have redone that process in a change in scope. So again, Kurt is still with us. And then the Hostella group, that is Craig and the one and only, of course, who started this program, who is the predecessor in this work and really actually got us to where we are in our APCM program. So Craig is very much still involved with both our network side, our clinically integrated network, which is the Community Health Center Network of Oregon, Chichno, or the network, depending how you want to call that, but involved there and then involved with the association as well and doing some of this APCM work as well. And last but not least, without OHA, we couldn't do this work, right? Without the state, and it was really critical that the state was involved and that it was the association and health centers bringing this model to the state, but saying without the state, we can't do this, right? So they do all of your rate setting, they do a lot of the reporting, right? The accountability, all of the pieces that are on that side, stay with the state, and you're working very closely with the state. As the association, we are meeting actually every other week with the state to ensure that we are in touch, we are supporting, and we're aware of what all the different components and pieces of the program are. So the three staff that currently support are listed there, and many of you have probably seen them in some of our forums. You've probably emailed, you may have talked to Adrian or Jennifer over the last year or so, but there are three full-time staff that support the program on the OH side or OHA side, in addition to actuarial staff and the leadership of OHA as well, being aware and kept informed of the program. All right, just very quickly wanted to reflect on as I was building out these slides and thinking about how we got here. What I did want to go back to and very much ground us in, again, as we go into the next iteration of this work, is where we started, right? So when we go back and look at some of those founding documents and some of the work that was being done, there were founding principles and kind of what they called guideposts at the time that were put into place for this program from both the OHA side and then as the association and our health centers. What you have in front of you is what OHA wanted or found to be their guidepost and what was important at the time the program was implemented. It hasn't changed, right? When we look at that and we think about the program over the course of the years, it is still very much, I think, where the state is interested, remains interested, and has found value in our program. So as you look at it, is accountability for outcomes, right? And this goes back to the days of the triple aim. I guess now we could call it quadruple aim, but to that triple aim of improved quality, patient experience or population health, and reduce cost. Again, that was a big draw when we began the program and still remains something that they can account for, look for, and are looking for as we evaluate the program. No additional funding, right? So when we started this program, when Craig did those conversations with Bruce Goldberg and OHA leadership at the time, there was no additional general state or general fund available, and in that we were actually looking at shortfall years. Those were years that we didn't have any excess in the budget. And so it had to be budget neutral. It had to be something that didn't have to be funded by the state. And that has remained true. That is still something that, it is funded only in what the agreement is with the state, but there is no additional ask out of the general fund. And maintaining access. Again, reflecting back to 10, 11, 12 years ago, we were just underway in those initial CCO conversations. We didn't have CCOs 10 years ago, right? That model is just now entering its 10th year of implementation. And it was back in the MCO days, figuring out how to keep folks enrolled, who was eligible, and ensuring access, right? Which again is very much what our role is in this program. Looking at what our guideposts or what our founding principles were and what was really important in proposing this program and having this program was getting off that face-to-face visit, right? Or the fee-for-service model and paying for widgets and only being able to bill for what you saw the patient for and had a code for. And again, that is at the core and really what set us on this path. It came at a time when we were also doing the patient-centered primary care home model. You know, we were transitioning into that. There was a lot of work around getting that off the ground. And again, we had been doing that a little bit with HRSA and nationally as well. But it gave us the perfect opportunity to expand on that model and move us, again, out of the fee-for-service and face-to-face. A formal APM, right? It was really important that we actually had the methodology, that we had a program that protected PPS, but also gave us an opportunity, you know, to what some of you indicated even in your initial comments around the patient engagement and non-billable services of how we wrap that care around patients. And last but not least, and really what's going to set us on a path today, was that initial guidepost for us that was going to be a bridge to value-based payment, right? When we started this program and when Craig and Laura Sisolak and a number of folks, we looked at where were we going, or was the writing on the wall, it was thinking about how could we take those outcomes that we felt very strongly about transitioning our care and wrapping the care around and getting to those outcomes into value-based pay. And arguably, we've been doing some form of value-based pay in APCM, right? You are getting paid for outcomes, you are changing the model of care, the care model has changed, but we haven't fully taken on the downside risk or done the population-based kind of attribution and metrics. Again, that was intentional in the model, in part because of our PPS, but also not necessarily being on a level playing field, right? There was that built-in accountability that said until we have social risk adjustment or some kind of risk stratification that levels the playing field as value-based pay goes forward, we're unwilling to put anything at risk. So that is where we were 10 years ago. That is how the program has looked for the past 10 years, or again, 8 years that we've had the program, and really scaled the program up. We grew that program exponentially. And it is now time, especially in light of where the state is and some of the opportunities, to again look at where we might go in this value-based pay space. And I should say, folks, you know, if you're interested or have questions, please put them in the chat. I'm happy to keep an eye on the chat, or Tori can help me do that. I know this is going to be a lot of talking. I feel like I'm talking a lot at you. It is informational and I've got a lot to share. And then I hope to get, and I will leave time at the end for us to have a little bit of that discussion and conversation as we wrap up. But feel free to interrupt me in the chat and do it that way, and I'll make sure to keep an eye on that. With that, what I do want to touch on as we get into those opportunities and what we would like to leverage in the future is our successes, right? This program has been very successful, both for health centers and the state. And this slide, you know, may look familiar if you attended our February 8th session, the forum that we had just a couple months ago. We did do a presentation on this. Jamal Fuquan actually gave that presentation. And, you know, we really looked at, as we went through this assessment and evaluation process, you know, what has worked. What we know and still know, and it is still true, is that we are some of the highest performing primary or patient-centered primary care homes. The graphic there that's actually pictured is a little bit dated. That's from, I think, 2018, but still spoke in 2017, actually, still speaks to, again, the role that we played and the impact we had in the PCPCH program here in Oregon. And again, we built off of that as we built this program. But we also know, and I asked you about those care steps intentionally, right, is that there has been significant and measurable increases in those care steps, right? There's 18 of them. And in fact, I think 19 if you counted our COVID-19 vaccinations as well, because that's one we added during COVID. But again, we know that based on the reports you are turning in and that you're being accountable for to OHA. Improvements in quality metrics, right? Those metrics I know have changed and been adapted throughout the 8 years that we've been doing the program. We try to tie them to CCOs, to UDS, and to do as much alignment as we can. But we do know we at times have actually shown to do better, especially in CCO metrics, than our counterparts elsewhere in the model or across primary care. We've demonstrated cost savings, right? Many of you know or will be familiar with the 2017 Optimist report that the state did as part of the initial years of the program and really evaluating the program. It was to the tune of 17 million in cost savings demonstrated because of that ED and ER utilization going down as a result of the wrapping around care and the non-billable services. So again, we do know we can demonstrate. I will say we are overdue for the next evaluation and need to reassess that, and that will be part of something we'll be asking for as we go forward in this next iteration of the program. But again, we can demonstrate that and are pretty sure we can do it again. And then, as you all know and work in this every day, there is countless local level, right, clinical and community health innovations enabled by this movement to that population health payment. On the flip side of successes, right, comes the challenges. And really something that I think is going to propel us forward into the next iteration of the program is what could we do better, right? What could we change? What would actually make this program easier? One of the things that has come front and center, in fact, for really both our association and OHA, and we've particularly seen it at OHA with a fair amount of turnover in the last, not even 2, but probably 3 and 4 years, is there is a limited staffing at OHA to support the APCM program. When I showed you those 3 staff who are the dedicated staff of the APCM program, managing 22 clinics on this model and the amount of reports and the complexities and the questions that come in around this program, 3 staff and really 2 full-time staff is not enough. And we, again, have supported throughout those years, and especially through COVID, as there's been a lot of more transition, done a lot of work to moderate that, but we've also experienced staffing changes and turnover and changes in our program. So that's always going to be a limitation, but something that we want to ensure either is kept, at status quo or increased in the future with OHA. The increased complexities of new and existing reporting requirements. And again, you might remember these bubbles from Jamal's presentation previously. I cribbed this one and pulled it over because I think he did a really nice job in that each of those bubbles actually has one of the reports that you have to file, either with the state or with us as the association, in probably PDF or Excel form, right? There's no automation, there's no easy way of data going back and forth seamlessly between the 2 entities. There's no way for you to look at your own data within a clinic and having the right EMR or all of that engagement in these reports. So again, as the program grew, and I want to note that as well, that as we went through those 8 years of adding 22 clinics to the model, right, it got more complex. It didn't get easier necessarily, it got more complex because there's more to account for and more to keep track of. As part of that, the next bullet there is around, as the reporting got more complex, so the needs grew, it became about the reporting so much as it became about the intent of really iterating and changing the model of care, right? Of talking about your care teams and changing your care team, how you do those care steps, right? What does it mean to actually have non-billable services and building out group classes or using telemedicine and telehealth, especially as we, experience COVID, rather than just the direct reporting of the attribution of patients and the care steps that you did get done. Again, we scaled up. I've said that a couple of times. That's really been, I think, the primary focus and, the willingness of the state to do that, but also time to look at, let's take that breath, let's pause onboarding, which we are paused through 2023 on the onboarding process, and look at where we can be going or where we can re-innovate and re-engineer the program. And I mentioned the last bullet there, again, lack of automation. That does not exist. And I think it would be, and I know it would be, right, a benefit for all of you. All right. That'll bring us into the opportunities. And when we did that, kind of analysis and, SWOT analysis, if you will, the opportunities are there in a number of spaces right now and the landscape of Oregon. And what we really looked at, from that policy landscape to the payment landscape, and even nationally, at what exists or what might be coming down the pike and identified the following four. So those 4 bullets in front of you, the first being, and really a primary area that the state has been focused on, and I should say the state has actually had a health equity focus even before COVID, but I think solidified that in COVID, saw COVID exacerbate the health equity and health disparities across Oregon, has developed that strategic goal that they are eliminating health inequities by the year 2030. As health centers and in our model of care and that integration and everything that we do being based in health equity and now being able to actually hopefully demonstrate and pilot or work with OHA on initiatives that could help them meet that goal is a prime opportunity, right? And we are going to really want to articulate that. We're going to bring that forward. You're going to see that in the deep dive of the 2.0 model. Our CCO metrics, right? And especially the incentive metrics and the goals and the standards that CCOs are being held to. And, whether we like it or not, CCOs are what we do in our Medicaid model. That's largely the population that we see, and of course, in the APCM program that is tied to. And really important to think about, how do we position you with our health centers in the APCM model to help reach the goal, and you as the health center to reach those goals that your CCOs are going to be asked to reach. One of those being 70% of all primary care payments in primary care in a VBP arrangement by 2024. So we're about 2 years out from that goal needing to be achieved. Many of you are probably, thanks Blaine, seeing that you're jumping, but I appreciate you joining. Are seeing probably that scale up from your current contracts of, what's in outcome-based measures, in the incentive measures you're being asked to do, and what that's going to look like. And so how do we help bring forward what works in APCM to actually help meet this goal within your CCOs? There is a social determinants of health metric planned, and it's actually a new incentive metric planned in 2023. Which again is not very far away at this point in time, but it has been worked on. We have been part of those conversations. We've done a lot of work in the Z code space. And again, looking at how do we bring our program to meet that goal or help you meet that goal, and again, continue to pull those dollars down into this program and into your health center as a whole. And then the final one there is CMMI, which is the Centers for Medicaid and Medicare Innovation, is looking again, and I say again, at APMs, in that this is the innovative arm of Medicare and Medicaid. And this is something that, APMs have always been on the radar since they took off, 10, 12 years ago, but are certainly of interest again to Medicare, and especially Medicare. I would say we're seeing a lot more of the conversation in kind of the Medicare space, but it does bleed over into the Medicaid space. And I think there's opportunity for us to demonstrate where our program still has the opportunity to grow, what we can do to be or continue to be innovative, and how we can continue to do that in a Medicaid option. And everything we're hearing is that that's going to happen between now and about 2026. So we have a little bit of time, but again, prime opportunity to position and think about what we do within our APCM. The other opportunity that we really want to, I think, emphasize and call out the loudest, again, because that was our guidepost as part of doing this program, was that value-based pay element, right? And trying to bridge our program into a value-based pay model in whatever that looked like. And because of where the state is in terms of state work that's happening in our VBP compact, which that is actually a collaboration between commercial payers, the state, providers, and Medicaid as a whole, of really thinking about what are those principles and guiding principles for a VBP model, that would cross all of your payers and maybe align some of that work down to the CCO level, right, of where the state is really trying to drive VBP. And so as we looked at that, I will give credit to Simon Parker Shames, who's our data director. He actually did this work in diving into what are the elements, right, of VBP that we know are something that's being looked at or that can be changed or as opportunities to change into. Where do those fall in fee for service? Where do they fall in the APCM? and where do we think we might actually have opportunities to bridge into? And when you start looking at that APCM versus the VBP opportunities, you start to see where we could bring in that social or the social risk and risk stratification, right? And in social determinants of health, it might be in the rates adjustment. We certainly want to talk about social determinants of health adjustments and how do we do that and start in that part and bridge to what it looks like as a whole, whether an APCM or any other contract you're looking at. All right. So as we then got ready to put together a framework and the proposal that will be in front of you in just a moment, we really had to think about what the priorities were of the work and where we want to be going or think is the right direction. And I will welcome your feedback, or if you have thoughts on any of this, please put them in the chat or hold them for the end of the session. But what is really front and center is we are looking to leverage the current state environment and the opportunities that exist in, again, VBP and equity without jeopardizing the program gains we've made already, right? So what our program currently is, what is working for you, and how that is actually impacting your revenue and your overall budgets is not something we want to change, but we would like to build on, do better, and then build in some of these other components that, again, we didn't necessarily get to in the current model. You'll see them listed there. I've got three, that we would like to focus on. The first of that being, and what is really important to start considering, is risk adjustment. And again, that can be in social determinants of health. It might be in race. It's risk stratification. It's all of those components of how do we build that in, not necessarily into a downside model, but into a way where we can stratify and then be, considered in a level playing field. We'd really like to streamline and automate data. I imagine you would as well, right? If we had a way to get that data back and forth between OHA and you as the health centers, and again, to actually evaluate or streamline your own processes as well for those workflows. And then promote and be recognized as trainers in the care model, which we have been historically. We'd like to continue to be at that forefront and really thinking about what does it mean to do this care differently or provide, value-based care, and traditional mindsets, right? How do we stay open to that? How do we continue to stay there as you come out of COVID, as you start to get back in whatever the new normal is, post world. And the next bullet there, what I will just, I'll let you all kind of look at that and reflect on that as well, but we will do that through iterating the program across a number of these parts, right? And some of these you do, right? The attribution, I want to stress that there are things we do well in APCM or that you have gotten used to and actually are more advanced in APCM than you would be if you weren't an APCM clinic. And that is things like attribution, patient rosters. We do quality outcomes. We're already accountable, but again, how do we expand on those or use those in a different way that grow our model further? All right. So with that, this again is just the vision. It aligns well with the priorities, but kind of gives you that same sense of just, we really want to go from where we are, grow on those successes, re-engineer the program for clinical innovation and center around equity, and showcase the excellence that we continue to have. Okay, we're going to jump into the framework. Are there any questions? I'll take a breath here and want to just make sure I give folks a little bit of time to digest that. I know it was a lot. Are there questions either in the chat or if you want to come off mute? Let's take a break before I dive into the actual framework. Okay, not seeing any yet. Again, feel free to keep the chat open or to send those along. I know it's a hard time of day. I hope I'm not boring your socks off, but with that, we'll jump into the framework itself. And then we will have a little discussion time at the end as well. So with that, what I want to emphasize as we start into the framework is that this is a long-term plan. We are looking at probably a 2-year implementation for the 2.0 work. I mean, there's a number of work groups and focus groups and things that we will need to actually have in place for this to be fully implemented. But what we have done and what we are planning through at least this summer right now is the timeline in front of you. I apologize, I'll get those all up for you. In that we have spent kind of the last about 4 to 6 months actually developing this, doing that analysis, doing that evaluation to figure out where we would like to go in the program. We have spent the last quarter since the new year, right, in our own forum of really starting to propose this, to have the conversations, and of utilizing our APCM steering committee, right, that nimble committee that is that 7-member committee that informs and is able to help guide this work in thinking about what we wanted to do. And that was kind of in the Q1, January and February of this year. We are doing informational sessions in this month in April. There's 3 of them. So this is the 2nd session that we're hosting. I've got 1 more to go. And then we are hopeful that in May and June, we'll be having conversations with OHA. That is our next entity that we have to propose this to, take this forward to, and get buy-in from. And those conversations are starting, but we'll go fully into May and June with the hope that we will have a final agreement and product probably by June and July of this year, with new participation agreements being signed sometime in July and/or August. So it's iterative, right? Things happen. We know that we need to pivot and change. I'm hopeful that we will hit that goal of July, but know that we may need, even a few more months past that. But again, this is just the beginning. We would launch in July, and it would be a 2-year process, at least from July of 2022. All right. For those of you who joined us at the forum, if you were able to do that, or if you would like to get that deeper dive and a little more analysis than even I'm going to dive in today, we're happy to share those slides, but this will probably look familiar. And so what we are actually looking at and what we came up with as part of this framework was 4 goals that, again, would re-engineer our program for equity and for innovation, right? Coming back into that innovation and accountability space. You'll see there, goal 1 is the renovation and redesign of the program. So again, really thinking about that automated data exchange and what the reporting requirements could be iterated to be, if not, 25 reports that you're filing throughout the year. We want to maximize interoperability, and that's really thinking about how do we do that in a more captive way, right? Not in the larger HIE and EMR conversations, but how do we do that in a way that brings in even some of the social determinants of health, the REAL-D, SOGI, all of the data components into the model, and allows us to analyze and use those to actually inform what our outcomes are. The 3rd goal there is equity, and I know you've heard me say it a few times, but again, this is where we really want to tie and leverage with the state of integrating, right? How do we look at our own health disparities, the outcomes we would like to get to in that population health model, using what we've already do well, but do better, and pilot that with the state. What would make sense for the state in piloting those community interventions. And then go forward, be no surprise, again, as we think about bridging to what is today's value-based pay and being positioned to meet the goals of CCOs, of your commercial payers, and of APCM in reaching a different way to get there. So I'm going to dive into each of those. They do include, as we go through the slides, the timeline for each goal, the milestones of each goal. There is cost estimates built in, and again, they're estimates at this point, and then some of the success metrics as well. Okay. Sorry, folks, it does not want to switch forward there for me. All right. So there's those same headers again with the goals themselves in terms of renovating and redesigning our APCM operations. This particular goal, as you'll note here, actually has a short-term and a long-term track. And this is largely with data. When we're talking about automation, especially for the state, that is a not fast process, right? We know that that's going to take a longer amount of time, and that standing up a new data system or a module, there's actually opportunities within our MMIS system, and that's the system that the state uses for all of the Medicaid operations. There is an opportunity to bring modules in that would actually do this automation and would actually probably assist in other programs that the state has or is working with the different safety net providers. You'll see the cost estimate is actually tied to that particular body of work. And what it would take. There's federal dollars that we can draw down. We're going to be asking the state about interest in, doing that kind of work of drawing down the federal match, and very less, I guess I would say, amounts the state would have to put forward. But in the short term, really trying to think about how would we expedite getting that automated data? Is there a way to do that, especially in light of work that the network, so our clinically integrated network, is doing in terms of a data platform? Or is there a way we could actually have a contractor do that work with OHA as well? So that's what you're seeing mostly in this particular track. And again, the short term of really trying to get at that data, and then the longer term goal of having true automation and a system built at the state level that will better automate, and again, push and pull the data back and forth between the clinic and the state. We'll move over to goal 2. And again, this is the interoperability and really thinking about how we use the information and how we use that community level information as well. So this one is just one track or kind of one timeline. But again, thinking about how do we get at, things like collecting social determinants of health. So when you are using tools like Prepare or whatever the platform is that you're collecting that data, it sits with the clinic, right? At this point in time, you are holding that data. You have the care steps data that is being reported out, but how do we tie all of that together and actually think about the workflows, the community information exchanges that are out there that are being potentially implemented or you may be working in, and building those technology infrastructures, again, that will get us closer to piloting and working with the state to figure out, what are those areas that make sense, or the pilots that, don't have to stay pilots, but hopefully become more permanent in the future. And again, that cost estimate is based on what the state could pull down in some federal dollars, not necessarily what, we need to put up or the state would even have to pull down. Moving over to goal 3 is our health equity goal. And as you'll note there, it is going to think about the Real D, the SOGI, and then that social risk data to pull forward, and to demonstrate what we do in the equity space and how we want to show the impact we're having on reducing disparities. It identifies those pretty early, I will say June of 2023, right? That's within the next year or so that we would be looking at getting that identified. And identifying what it is we've done well, right? How do we share those success stories? How do we give something back to OHA or work with OHA on things that they could take forward into other spaces? I think what OHA and what we have heard a fair number of times now is not only are they standing up equity teams and equity is being built throughout everything that OHA is doing, they are looking for those hard stories of success, right? And what could they do, or what can they help fund or work with us on that's going to reduce those inequities and actually be implemented in a broader space. And our final goal there, and I am going to get through this so that we can get to some of the feedback or questions that you have, is the bridge to value-based care, right? And pay as a whole. But, what could we explore that is new, innovative, or make some of the reach outcomes to get to that goal of changing potentially our attribution or building in that social risk. So again, we are looking at potential LAN alignment, and you'll see that in the first success metric, right, of would it make sense to use the ACP LAN. Some of you are already in that. You may be advanced in that. You can be as far as, even LAN 4, you might be in 2, but we'll talk about that as a whole for APCM clinics. Testing modules with the state to see what works. And then really pulling forward that VBP shared savings, some kind of model, again, that incentivizes us to do this, but potentially allows either for shared savings or additional dollars to be pulled forward, if not the full downside risk either. And that's something we'll be in conversations about with the state and with all of you as we move forward in this particular goal. All right, I'm almost to my last slide, I promise. But what I do want to stress again is that this is a draft framework. This is something, again, we are doing informational sessions on, and it is a 2-year process. This is the very beginning. It's not actually even the true countdown yet. We're just in the informational stages. It will take us 2 years at least to implement all of those 4 goals that I just shared. We do want your feedback, questions, and input on the proposal. If not today, you certainly can think about it or send those to Tori or myself, in days to come. We will be working closely with OHA, right? We can't do this program without OHA. It's why our program has been successful in terms of the partnership that we do have with the state and the work that happens there. And that as this goes forward, even as we kick it off, and if we do kick it off or when we kick it off, it will remain iterative and will build on those current successes. All right, with that, we have just about 15 minutes left. I've got a couple questions here just to help frame your thoughts or to generate maybe those thoughts. But you may respond to any of them, and you certainly are welcome to respond in the chat or by email or here as well. But I would love to know, what did you like in the framework? What's working well in your program that you don't want to change, or that you would see being something that we want to keep? And then what's missing, if there's anything missing in the framework.
Hi, Danielle. This is Carla Jones with the Community Health Centers of Benton and Lynn counties. So I have some scattered thoughts and some comments. I'll use your framework first to answer questions. But what I like about the framework is the focus on reporting and interoperability. What I've learned in, value-based payment methodologies is that it's really difficult to get to a full risk model without being informed of where you're at in order to make a difference. We actually have a value-based payment methodology in place with our CCO Intercommunity Health Network, where we're only incentivized this last year, upside incentive only, not downside, but an additional upside incentive to reduce or maintain or reduce the healthcare growth spending, the growth, the growth rate.
The growth rate, yep.
Yeah, to 3.4% below or below. But what I don't have, right, because it is inclusive of all services, is no ongoing report that shows me, some information that I can use to actually make a difference. It's just more of a, here's where you're at. This is what we've learned in our report, but I have no detail to really help make a difference in those, ER visits and inpatient stays and high cost patients. And so I think that's an area where I do like the framework that we're focusing more on reporting. I think that there's also some conversations where, we'd like more access to making our own authorization decisions. We're limited by our CCOs right now with their HMO type of processes right now, and we could really create some efficiencies in being more responsible and having more control over authorizations when we're on the hook for the final outcomes of payment. So those are just a couple of examples of reporting that I think is really important in my experience of being of getting to a full risk model. Is I've got to have something in order to make a difference. What is working well in our APCM program is using the care steps and being able to consider that for engagement. It's super important for us, and the payment and the way that we're paid for the wraparound payments, in addition to the PPS and our APCM payment, really does allow us to have the care teams in place that we need in order to have the outcomes or to produce the outcomes that are being seen. And I just think that that conversation of how much it costs to do this work is hopefully something that we can help with examples of the return on investment, but that it's, it's not something that you're going to see tomorrow. We're investing a lot of time in maintenance and preventive work that's helping overall community health. And so, but we're without those robust care teams and that huge navigation team that we have, we wouldn't be able to make the difference that we're making. And so just, whatever methodology we put in place, it really does need to make sure. And I'm glad we're using thinking of social determinants of health and a risk adjustment type of methodology when we're considering that. And I think that's what is missing. So I'm glad that there's a focus on a risk adjustment methodology. The other piece that I think is key is patient panel management that's missing. So yeah, we have the re-engagement reports. At the same time, we don't have any access to the one system really. And we don't really have that access to addresses and determining whether or not patients really are in our area. And so we're on the hook for quality metrics, but somebody lives in Hawaii because the state hasn't updated anything. And then at the same time, we engage with somebody just right past the cuff, and then and we're not incentivized for that until the next cycle. And so I just think there's still some flaws in the patient panel management and really understanding who are our patients that we're being evaluated on, and that we have control in order to make a change. I've been having conversations recently with HRSA, and then I'll stop talking, sorry. But I've been recently having conversations with HRSA about what's used. UDS data, for instance, is used in determining our grant funding every year or every other year. And with that, it looks like our agricultural migrant seasonal worker numbers continue to go down, or they fluctuate. And it's because they're using an archaic system in order to determine who we're reaching. And, we've been changing our model to be more innovative. So I like that we're using the term innovation, because the only way we're going to get more access to care is by changing the way that we're providing access to care. And so I'm not loading people into OCHIN. My navigation team is going out to farms and helping serve families and workers by the hundreds and thousands. And we're not getting that credit. And so, I think having a reporting system, focusing on a reporting system that's not your typical standard EHR type of model, is going to be really important in order to make sure that we're getting payment for the work that we're doing.
Thank you, Carla. All super helpful. We are also taking notes and recording this as well, because all of the feedback will be instrumental as we go forward. So greatly appreciate that. And Max, I do see that your comment / question there, which actually relates to what Carla was talking about in that cost growth curve. Yes, to a degree we're talking about it. I think it could have a role here. And for folks, that can't see the comments, is how do you reconcile that 11% inflation and under the 11% inflation in healthcare staff that have been pushed hard through the pandemic? And then in other words, you get a 4% raise, so 7% real wage decrease, and the implications that has. Again, I would say that's going to have interplay with what we're doing in APCM. but also is work we are doing in our sustainability and operations teams. We are working with the state in all of that workforce, and very much participating in the cost growth committee. They have a funny name, but anyhow, the group that is doing it at the state level with Jeremy Grandehey.
Yeah, my suggestion would be that, I think that target was set well before inflation accelerated. And rather than continue to march to an unrealistic target, like having the hard conversation to say, do we need to reset the target? Especially, it feels like I've had this discussion with some other people, like, sometimes, when we're getting like these 2% inflation adjustments, it feels can be really disrespectful to these staff who have put themselves at risk throughout the pandemic. They were the first ones out there on the front line when the doctors were, dying in China, and we told them, well, you got to go out there and test people. And now we're like, oh, sorry, you're going to take a 9%, real wage cut. And, what have you done for me lately? Forget the last 2 years. It just sets a really bad message. And I think we'll have a mass exodus from healthcare if that is how it comes out, right? I hope that doesn't happen.
Yep. No, totally agree. And like I say, we are working a lot of those different conversations right now. I think that is all percolating. And yes, we can think about if we're, and what could this program do to actually offset, to your point, some of those potential revenue losses.
Yeah, I'm sure there's some opportunity to squeeze costs in other areas, but I'd just be realistically going from, 11 down to 4 seems pretty tough.
Danielle, I don't know if you can see Christie's question in the chat also around the mental health carve out, and if you wanted to speak at all to what we've been talking about of potentially revisiting that along with oral.
Yes, thank you, Joan. I hadn't looked back to my chat, and thank you, Christy. So for those, if you can't see the chat, is it time to carve in mental health? It's challenging to capitated models with still being encounter-based. And thank you, Christy. That is an area we are also potentially thinking about building in. And we have heard certainly from not even just our APCM clinics, but our non-APCM clinics, that actually the carve out, right, of both mental health and dental have actually kept them out of the program, or don't, act as a pull-in when you have higher rates. And you're right, being encounter-based makes that tougher to parse out what you're doing for patients. So I think that will be on the table in terms of, could we develop either a mental health rate? Can you actually come up with a rate that could be both? And I want to be, cognizant of that's 22 clinics that would need that built back in, plus any additional clinics in the model, but it could be done, right? And especially if we can get OHA to staff up a little bit on their side. But it is under consideration as well. And thank you. I meant to bring that in as well. All right, I know we're coming down to our last 2 minutes, and so appreciate all of you that were able to hang in there with us as they come to the end of our days, or almost the end of the day. Again, I'll encourage you, as you think about this, we will send out one of the recordings so that all can go back and watch, in addition to Jamal's deeper dive on the full framework, if that's of interest. But as you have questions, if you think of things, if you'd like to participate in some of the work groups or work going forward as we really do actually start to implement pieces of the framework, please feel free to let Tori or myself know. Send us an email. You can drop it in the chat right now, and we will keep you, on deck to help inform that as we go forward. But there will be opportunities once this takes off and in whatever iteration, again, we agree upon with OHA. All right, well, I won't keep you a minute longer than I have to. Thank you so much. And we look forward to hearing back from you and working through the next iteration of this program with all of you as well.
Thank you.